brains are working this morning. So yesterday was the overview. Chronic Inflammatory Response Syndrome. 20% of the population carries gene sequences that create susceptibility and can lead to long-term consequences. So that's the model that we're in. Today we're going to go deeper. Like you, I've been in this field a long time and listened to a lot of lectures, and sometimes people can kind of wow you with the science and they do a little hand waving, but at the end of the day, you feel like, okay, what do I do? So I don't want you to leave without that very particular knowledge. I feel really strongly that I want you to not only understand, but have some real tools to apply. So the rest of these talks are truly sort of a step-by-step approach for how do I evaluate these patients, what labs do I order, what are the correct ranges, how do they meet criteria for diagnosis, and then the treatment sequence itself in a very specific order. And I would be shocked if you sort of just absorb it all at once and say, okay, now I get it. This is something that you'll come back to and look at, but I promise everything is in the slides. I even took some time to take the typical handouts that we have at my clinic and I put them in the slides so that you could download them and just reproduce them. I'm fine with that. So whatever you need to do to be successful, to begin to organize your thinking, because I know this is probably new for many of you, if not all of you. So neuroinflammation, that is the key for what this entity is. This is, yes, inflammation, it's chronic, it doesn't turn off on its own, but in particular it's inflammation within the nervous system. And certainly it affects other components of the body, but this is a brain on fire, this is the autonomic nervous system on fire, it's the peripheral nervous system that's on fire, and that's the genesis of a lot of symptoms that you'll hear from patients. So it's important just to understand that piece. And more broadly, though, I like to think of it in terms of one of the most important subsystems in the body, which is the gut-immune-brain axis. And when you look at the literature, there's a lot of discussion about sort of the permanent relationship between these three entities. The gut being a single cell layer thick, bound together through tight junctions. We have 70 to 80% of the immune system that lines the digestive tract. And then you have the entire enteric nervous system that innervates all along the digestive tract. And we have as many neurons in the gut as we do in the spinal cord. So they're in what we call permanent crosstalk. And it's a reason why when people end up with CIRS, that this is often where the majority of their symptoms lie. Because either it's a strict gut-related issue, the tight junctions are loosening up because you have low MSH, or there's triggering of the innate immune system along the gut lining, so people have a lot of food sensitivities and gut reactivity, or there's inflammation of the nerves in the gut, and so now the autonomic component of the digestive tract has become impaired. So we see a lot of patients with gastroparesis, gallbladder dyskinesia, motility disorders, constipation, alternating irritable bowel syndrome. So when you have patients that are localizing in the digestive tract, you have to think about these other components as well. So this is a kind of an important subunit for me, and then I talk about this all the time in my patient population. So as a quick review, CIRS, there's a growing awareness that these microbes are playing a role in chronic illness, and the terrain matters. Not everybody who sort of encounters these biotoxins becomes sick, but there is this HLA predisposition. And these chronic infections that can sort of take hold in this patient population just make matters worse. So not only do you have this chronic inflammatory response, but you also, in those that are infected, also have to deal with that issue as well. There are other factors that also alter immunity, not just biotoxins, but as I mentioned briefly yesterday, the presence of toxins, so organophosphates, heavy metals, PCBs, dioxin, phthalates, the long list of bad actors that bind to enzyme substrates and deactivate metabolic processes, they will make this complex worse. So in the context of dealing with this patient population, we do place some emphasis on detox, but that's a secondary issue. It happens further down the path of treatment. And I can tell you from experience, because I've made the mistake, if your patient is very neurologically inflamed, if their brain is hyperexcited, and their pH is still quite low, so they're acidic and they're not mobilizing their detox pathways very efficiently. If you start giving them chelating agents or natural binders that start mobilizing heavy metals and chemicals, you will make them worse. You will further excite their brain, and they'll decompensate, especially if they're in this category. And I've done it. I've made that error myself, and it's not pretty to see. And sometimes because the terrain is so impaired, we've had patients that have a baseline of psychoses and seizures and tic disorders and severe migraines, and all of that can be set off if you begin to detoxify them too early. Okay, so and even if you're doing quote unquote things that are gentle, I would advise against it. So you'll see sort of where that lays in my protocol. So again, what kind of inflammation is this? We're stuck in the innate side of the immune system. There's the innate and the adaptive. And this is a poor antigen presentation. It's a poor handoff from the innate side to the more mature adaptive side of the immune system. So by presence of these 9 HLA genes, these antigen presenting cells are not very efficient. And so you get this early but chronic innate immune activation. And we have good markers now to capture that dysfunction, which I'm going to go through in detail. But these are going to be likely analytes you haven't heard of, or maybe you have a little bit, but you don't have enough confidence in yet. So what it's not your general cardiometabolic inflammation. Typically speaking, these are patients that don't necessarily have high SED rates and CRPs. This is not from obesity and visceral fat. This is not your vasculopath per se. Now that they might end up there because obesity can be a component of this illness process, but that's not the core of this inflammation. You also will not typically see the presence of autoimmune antibodies unless they've spilled over into the adaptive side of the immune system. But that is a secondary consequence of this immune activation. The primary problem is here on the innate side, and so they remain chronic. It is systemic. So it can affect just about every system in the body. It can create a long list of symptoms, and I will give you the categorization of those symptoms and how to identify those patients when you do your initial intake. But one thing to really understand is that whatever the biotoxin is, this sort of global reaction that the immune system has and how it has these secondary and tertiary consequences, we end up with this kind of final common pathway. This is why you can't tell what the original biotoxic exposure was just based on how people feel, right? So whether it was Lyme or mold or ciguatera or Pfiesteria or dental issues or whatever it's going to be, whatever turned on that innate immune response, the body has a coordinated set of reactions. And that's why there's kind of a global set of symptoms and blood labs that will reflect that. Differential diagnosis is key, meaning you want to rule out other causes for why people feel sick. And one great way to do that is when you have patients and let's say they've seen their conventional provider and they've taken the typical list of medications, especially in this patient population. So it's going to be your antidepressant, anti-inflammatory, sleep aid, muscle relaxer, often narcotics. You know the list. It's the fibromyalgia chronic fatigue patient who's labeled as depressed with a sleep disorder and chronic pain. But if you've also gone through your functional medicine evaluation and you've tried to fix the gut and you've tried to balance their hormones and you've worked on their stress and you've repleted their nutrients and they're just not getting better, you've sort of completed, in a sense, that workup of differential diagnosis saying, boy, I don't know what's going on with you. You're just not really responding well to anything. I mean, maybe you're holding them together around the edges and they feel a little better because of, let's say, the manual therapy or acupuncture, botanicals or breath work or exercise, whatever it's going to be, but they're not quite getting back to normal. So there's this other piece that's going on with them. But understanding the innate immune system itself is not new. It's just new in terms of a language for healthcare providers. We've spent most of our time on the adaptive side, dealing with autoimmune illnesses or in the general inflammatory cascade because of cardiometabolic disease, heart disease, and diabetes. So the labels that you typically see don't locate us into the innate immune response, and yet this is a disease entity that squarely comes out of dysfunction from this, this part of the immune system. By 2000, there were over 50,000 papers that were published on innate immune activation, and in 2011, the Nobel Prize was awarded for a couple of researchers that focused in on the role of the innate immune response in a variety of chronic illnesses. So again, it's a brain on fire, it's a nervous system on fire. The cognitive issues are huge in these patients. They will talk about brain fog, fatigue, word-finding difficulties, short-term memory loss, obsessions, compulsions, as well as all of the mood disorders, depression, anxiety, panic attacks, social anxiety, fears and phobias are a big one. I'm now afraid of heights, and I wasn't before, and I don't really know why. I'm retreating from my social network. I just don't feel like I want to interact with people the way that I used to. And a lot of it is because the immune markers that are generated in this patient population, they actually bridge the blood-brain barrier. They break down that elegant but delicate lining. And what's interesting is the body has these sort of three barriers that all break down in this patient population. So you have the enterocytes with their tight junctions that break down. You have the endothelium in the vascular system, which also breaks down. And then we finally have the blood-brain barrier, the final barrier that breaks down as well. And the body is organized this way. And what's interesting is that these are physiological architectures that are supposed to open and close to make sure that nutrients get across the gut lining, or that there's appropriate immune activation along the blood vessel, and things have to get in and out of the brain as well. But mistakes can be made, and the problem is that the more inflamed the individual is, there's more direct injury to these linings, and so the brain becomes very vulnerable. And what happens is over time, as the brain becomes more and more injured, we lose production of those neuropeptides, these regulatory neuropeptides. So again, there's no difference in the exposure in terms of your symptom presentation. It could be mold from a water-damaged building, dinoflagellates, tick-borne illnesses, apicocomplexans, cyanobacteria. There's a long list, and sometimes you just don't know. And I'll get to, well, what do you do if you don't know? If you think it might be a bug, for example, how do we deal with that? And again, if you're thinking maybe this is Lyme disease, you have to check for those HLAs. 22% of the population carry these gene sequences that make them vulnerable. And so this is not an issue of likely chronic infection. In most patients that we've treated, we've been able to get them better not by doing more antimicrobials, but by instead correcting the underlying inflammatory response and also dealing with the organ-based injury. Because a lot of these patients, and I'll show you our data, end up with brain damage. And so there are three components really that you have to deal with. You have to make sure that they're out of the exposure, so kill the bugs or clean up the mold or whatever it's going to be. You have to turn off that inflammatory response, and there's a sequence for that. And then you have to fix the damage to the brain and the damage to the other organs. If you don't do all three, these people will remain sick. And so just because a person has symptoms doesn't necessarily mean that they're still infected. That is a key clinical pearl in this patient population. So don't get confused. So this is what we're going to go through in terms of our biotoxin evaluation. We're going to begin with our initial screening. So what are the symptoms and how do they group? What is our lab evaluation in terms of proteomics, functional labs, HLA sequences, infectious disease markers? I had mentioned this very important tool called the visual contrast study. This is a marker of inflammation of the optic nerve. It turns out that as the brain becomes more inflamed, we lose our contrast sensitivity. I also think it's important to do your complete history and physical, and then also a very good exposure history. So were you bit by a tick? Did you live in an endemic area? Were you ever in an apartment or a building that smelled musty or had some mold? Were you ever bit by a spider? Did you have funny rashes? Or was there ever a time when you had really high fevers followed by joint pain? You have to go back in time, and sometimes it's years, and don't be afraid to go back 10, 20 years. I have patients who are 45 years old. Their symptoms began when they started college. Well, it's because they were living in an old dorm, and they were sick ever since. Or they were bit by a tick when they were 13 years old and never quite felt right. afterwards. And they were treated with antibiotics, but things just never resolved. And along the way, they were given other labels, hormone dysfunction or adrenal fatigue or leaky gut or whatever it's going to be. But then you look a little deeper and you say, oh my gosh, look, you failed your visual test, your labs are abnormal, your brain scan's abnormal. This is what it's been your whole life. And it's very healing for people to finally name it and say, you know what, here are the abnormal labs. And they go, this is the first time that I've ever seen true abnormals, that we're not guessing, we're not squinting. And I think we all squint a little bit. We go, oh, this is high normal, or it must be because this magnesium is low normal. Well, these markers are going to, if these patients are in this category, they're going to come back abnormal. And it's very good for the patient to see that, and it provides a roadmap for therapy. So you do your initial screening. You say, yep, I think this is a biotoxin patient. They failed their visual test. They got a lot of symptoms. We verify with the labs, and then we look to see whether or not they actually meet criteria. So we have 3 tiers. The first is they need all 3, a known exposure, you've ruled out other causes, and they have positive symptoms in 8 of 13 symptom clusters. Now I can tell you some patients don't always meet that, but if they're getting close to those 8 clusters, you have a high level of confidence. And as I mentioned yesterday, if they fail their visual test and they have 8 clusters of symptoms, we have a 98.3% sensitivity, meaning you're 98.3% sure they're a biotoxic patient. And then tier 2, 3 of 6, meaning they fail their visual test, they have presence of the HLA markers, they have an elevated MMP9, they have abnormal ACTH cortisol, abnormal antidiuretic hormone osmolality, which is water balance, and then also a low MSH. So 3 of those 6. And then finally, tier 3, Conformation, 2 of 3. Their symptoms get better when you treat them. They pass their visual test with adequate therapy, and they have resolution of laboratory markers. So you have verification that, in fact, what you're doing is working and they're improving. And then you do your diagnostic refinement. So you say, okay, well, yeah, they're exposed and they meet criteria, but what was the exposure? Well, the 2 big ones in this category, and there are others, will be tick-borne illnesses and mold. Mold is probably the most common in this category. And if you think about it, 50% of all buildings in the country have mold, and 20% of people carry genes that make them sensitive. This is incredibly common. Now, we know there are other factors and features that occur because of building practices now, off-gassing from new furniture and MVOCs and VOCs and all sorts of other things that people can now encounter in indoor environments that can also trigger this response. So it doesn't always have to be mold, but it's often mold. So how do we begin to dissect that component? So you ask yourself, well, what's the exposure? Well, I mentioned the Nano trap urine test yesterday, this antigen trapping test. I think that's very good. It's not perfect. There was discussion in the evening about what about other tests. The reason why I push this one is because even though it's novel, it's not your standard, at least they've collected data and published studies on outcomes. It's not just a technology that's been verified and approved by the FDA, but in fact, at least this one has met a clinical standard to show, within a certain sensitivity and specificity that it works and it's real. And we rely on it, but I will also say it's not perfect. Now, also, they only have primers for Borrelia, for Lyme. They don't have them for the co-infections yet, for the Bartonella and Babesia and so on and so forth. They are developing them. And I'm not tied to this. I mean, if a better test comes out from another company, great. The more data we can get on whether or not this is Lyme, very good. And I have a couple other tricks that I'll show you in terms of could it be other things or could it be Lyme based on the lab data and some other workup. If it's mold, we recommend something called an ERMI home swab kit. This is the Environmental Relative Moldy Index. This is based on PCR technology, well verified by the EPA, was actually developed by the EPA, far better than air sampling. It's a home mode swab, and I'll show you what that looks like as well. We also have our patients do cardiopulmonary exercise testing. Their VO2 max is dropping. As I mentioned yesterday, they have poor exercise capacity, so we can verify that in our evaluation. They'll often also have excess right-sided heart pressures, pulmonary hypertension, and even elements of interstitial lung disease and restrictive lung disease. We also order the brain MRI, so we like to verify to say, yep, you've been exposed, you're inflamed and your brain is changing. We have lots of data. In fact, my clinic has the largest data set in the world on brain-related changes due to Lyme and mold. And we've published this a number of times to show there are very specific areas of the brain that alter because of the exposure. This is one of our other tricks to say, you know what? You meet criteria for a biotoxin, but you didn't test positive for Lyme, but your brain scan shows Lyme. So I'm still leaning towards Lyme. Or conversely, they fail their visual test, their blood markers are abnormal, and their nanotrap is negative, and their brain scan shows mold. And we say, okay, it's probably mold. And then finally, sort of the undiscovered country is the transcriptomics. This is sort of, again, the music that's coming off the DNA. So we use next generation sequencing to take a look at gene expression patterns in this patient population. All of this is used to refine our idea of what we're looking at. So here are symptoms. This is the list. There are many. Fatigue, headaches, light sensitivity. This is all from the inflammation around the dura. Memory and word finding issues, concentration and focus. Oftentimes these patients are on some form of Adderall or Strattera or some sort of medication that helps them concentrate. Pain-related issues, unusual skin sensations, shortness of breath, and sinus problems. This is from the pulmonary hypertension and the restricted peripheral blood flow, cough and thirst and confusion, so on and so forth. Here is how we categorize them. So this is the 13 categories, and all they need is one symptom in each to qualify for the 8 of the 13. So this is a nice way of just looking at their symptom list and saying, okay, I'm going to go down the checklist and see, do you have headaches? Do you have brain fog? Do you have fatigue? Do you have appetite issues? Do you have digestive complaints or difficulty concentrating? Do you have joint pain or disorientation or static shocks and vertigo or abdominal pain, so on and so forth? And so this is how they meet criteria. This is all in your slide, so you can actually just download this and use this. So on to the visual contrast. So let's say you've done your symptom evaluation, say, yeah, boy, you got a lot of symptoms. I'm beginning to think maybe you're a biotoxin patient. Let's get some objective verification. So the visual contrast study has been used for over 40 years, developed by the military in use of non-biological toxicants and now biological toxicants, and it was a field test. So they would send out workers into a community with these cards, and what they have are gray circles with these lines imprinted on the circle, and the lines are either pointing right up and down or left or right. And the patient is asked to cover an eye, and they stand 18 inches away from either their computer monitor or the card itself, and they try and guess which way the lines are pointing. And it turns out that the way the test is organized is that the shade of gray gets lighter and lighter, so the contrast between line and background gray starts to become harder to discriminate. And there are 45 of them for each eye. And so at the end of this, they get a pass or a fail. It's very simple to do. It takes 10 minutes. There's a website that they can go to. It's $15, and they cover one eye, they do the other, and they're done. And I can tell you right there, if they have symptoms and they fail their visual test, we know what we're dealing with. They've had an exposure of some sort. Now, caveat being, no matter how inflamed some people are, 10% of the population will pass this test. So if they pass it and they have a lot of symptoms, again, it's not a hard criteria, but it's important. We also use it as a marker of improvement, because if they start off failing the visual test, you want them at some point to pass it. They need to pass it, actually, to go to the next step of therapy. What that means is that they have less neurologic inflammation in their brain. And sometimes it takes patients a month, and sometimes, unfortunately, it can take patients 6 months. The clinical pearl here is if you start treating a patient and it takes them months and months and months to pass the visual test, it usually means they have an ongoing exposure. That they claim they've cleaned up the mold in their home, or they've started their antimicrobial therapy, but it suggests something else is going on that is further inflaming the patient if they have trouble passing the visual test. So this is our data. This is what a visual contrast study looks like when the data is extracted. And we know that patients start losing their contrast capacity out here. So the issue is there's a relationship between acuity and contrast. So acuity being sort of clarity of vision, patients need to have corrected vision to at least 20/50. So you don't want them being compromised in terms of their ability just to see. So if they need to wear contacts or glasses, that's fine, because we're not testing that. We're testing color discrimination. And this is our data as well. So we tested patients before and after Lyme treatment, and it turned out 20% of the population failed the visual test after therapy. And we said, boy, that 20% number just keeps coming up. And it's because even though they cleared the microbes, they remained inflamed. And we used the visual contrast study to verify that. And we've seen this in lots of different patients. So everybody loves statistics, right? Okay. So as we started looking at our data sets, we could verify that patients statistically would fail the visual test after therapy for standard of care for Lyme. And it was very reproducible for us. And it was because of the presence of those HLA sequences that we were able to verify that when you had one of those 9 gene sequences on chromosome 6 and you had a known exposure, people had trouble passing the visual test. So here is our handout that we give patients on how to perform the visual contrast study. Okay, so you can extract that from the slide, reproduce it. If you want to use it, fine, no big deal. Sometimes patients want a little extra information on why am I doing this and how do I do it. So this is what we give our patients. It's just a written description of this test itself and how to perform it properly at home. So it needs to be in a well-lighted room. I typically suggest during the day. Make sure that you're wearing your glasses or contacts if you need to, 18 inches from the monitor, and just complete the test. And then what I have my patients do is just contact clinic and let me know if you pass or fail. I want the verification right away. So, okay, so now you've begun to vet the patient. They've begun to meet criteria by symptoms. They failed their visual test. You're getting a sense this is a neurologically inflamed individual. We think they've had an exposure of some sort. You've done your exposure history. You're beginning to get an idea. But what about biological verification? Let's talk about proteomics or blood labs. These are those protein markers that I've been referencing. So this is a new nomenclature for you. C3A, C4A, TGF-beta1, MMP9, VEGF, MSH, VIP. This is your new language of understanding the body's innate immune response to this exposure. So we're not in hormones, and we're not in gut function, and we're not in normal immune function. We are specifically in a very discrete category of innate immune activation. Now, as a result of this, we see hormone dysregulation. They will have abnormal cortisol. They will have abnormal estrogen and testosterone. There is no doubt that they can have hormonal imbalances. There might be spillover into autoimmunity because of this actor, TGF-beta1. TGF-beta1 is expressed by Th17 cells in the periphery. TGF-beta1 drives autoimmunity once it increases above a certain level. And so this has been linked with rheumatoid arthritis, with lupus, and a variety of other autoimmune illnesses. Capillary hypoperfusion, you get 2 problems. Blood vessels are constricted because of this guy, because of C4A, and also because of another one which I'll mention, vascular endothelial growth factor, VEGF. So people get really tight. They get tight in their pulmonary tree. They get tight in their periphery. They'll have cool extremities, Raynaud's-like symptoms, poor exercise tolerance. They cannot get oxygen and nutrients to the tissue. This is not a mitochondrial disorder. You cannot fix them with ribose and carnitine and CoQ10, no matter how fatigued they are. Okay, so I know we like to talk about these things, and even though their cortisol levels are flat and they're tired and they have hormone imbalances and gut-related issues, it's not that per se. You cannot fix the leaves to manage the roots. You gotta treat the roots, and all the other things start to get better. These other therapies that I know you guys are really good at will start to work in that same patient where they didn't work prior. We also have to eradicate commensal staph. This is a really important one. So as MSH levels drop, among other things, the immune system starts to become weaker. And so while one aspect is inflamed, the person becomes more vulnerable to chronic infections. The most important that we have found, which came out of data from Australia, was an infection in the deep nasal passages. And it was a staph infection, and a very unique one at that. And I'll talk about that a little bit more, but you got to, if it's there, you got to get rid of it. Most people who have a low MSH will often have this staph infection. And then also correcting cell level immunity, and we do that through the protocol itself. Okay, time to take a deep breath, because here is the cascade of proteomics that occurs in this patient population. So burn this into your head, okay? It starts with an exposure, okay? And it can be any kind of exposure. As I said, there's a long list of biotoxins that will trigger the innate immune system. If people, and I know the writing is small, but if people are in the 80% category, if they are able to dispose of biotoxins easily and they trigger their adaptive side and make antibodies and clear efficiently, they will not become chronically ill. But if they're in the 20%, where they have presence of the HLA and they can't clear because they've triggered their toll-like receptors, and now we have these dendritic cells that have poor antigen presentation, they start developing this early cytokine storm in the brain. And so it's a serum sickness essentially, but it's locating inside the central nervous system. So surgeons worry about a systemic inflammatory response after cardiopulmonary bypass, for example. The body can release a huge amount of inflammatory proteins, and they really get concerned with this. This is the chronic version of that. It's a lower grade, but it's locating in the nervous system and in the brain in particular. So you get this cytokine storm, and one of the problems is we get damage to key areas of the brain. One being the posterior hypothalamus, so there's damage to leptin receptors. People's leptin levels start to climb, their appetite is dysregulated, and all of a sudden they're packing on 30, 40, 50, 60 pounds. And it doesn't matter what they eat, and it doesn't matter how much they move, and it doesn't matter what supplements they're taking, they will remain heavy, and they will have a difficult time losing that weight because it's brain damage, and it's not their fault. So much of how we approach obesity in this country is a lifestyle issue. It's choices. And we kind of locate blame, in a sense, on individuals. Now, clearly there are people who could do better in how they eat and how much they move and all of that. But this is a patient population where it's really unfair. And I've had patients break down saying, the worst thing about this illness is I'm 60 pounds overweight and I can't get it off. It's terrible. And so we want to be very sensitive to this issue. The other component is we start to have impairment of the anterior hypothalamus, with limited production of melanocyte-stimulating hormone, vasoactive intestinal peptide, and arginine vasopressin. So what happens when MSH starts to drop? This is probably the most important hormone you've never heard of. So I'm sure you're all familiar with the reproductive hormones, estrogen and its downstream metabolites, and progesterone and testosterone and DHEA and growth hormone and cortisol and so on and so forth. MSH is a neuropeptide. It's a regulatory hormone that controls a number of processes in the body. And so it regulates sleep. It's permissive for melatonin production. It's important for endorphin levels in the brain as well. So not only do patients have disrupted sleep, but they also have pain-related syndromes. We had a talk last night about the role of low-dose naltrexone. Low-dose naltrexone might be helpful in these patients to help regulate endorphins, but only occasionally. MSH is also really important for tight junctions in the gut. So as MSH levels decline, the gut gets leakier and leakier and leakier. So the problem, therefore, is not just the therapeutic strategies of shoring up the tight junctions and giving glutamine and arabinogalactans and butyrate and so on and so forth, but in fact, you got to correct MSH to heal the gut. You got to get the MSH coming back up, which means you got to reduce neuroinflammation. That's the only way to get MSH back up. We also see loss of sort of immune response in general, but also MSH helps to control cortisol and ACTH, so it's permissive for that as well. And it's a double whammy. Remember yesterday I mentioned that hippocampus is central for controlling the stress response, and as it becomes dysregulated and the architecture of the hippocampus starts to change, we see abnormal cortisol curves. Well, MSH plays a really important role in that regard. So we also know that as the brain becomes more inflamed, in mold, the hippocampus swells. So there's a direct insult to the stress response and an indirect one through MSH. In addition to that, we see activation of aromatase enzyme. So patients are over-converting their testosterone into estrogen. So men start also packing on the pounds, and women are getting hot flashes and night sweats because their estrone and estradiol are really, really high because the aromatase enzyme is working overtime. In addition to that, it's really important as a control modulator for antidiuretic hormone. So this is a hormone that's released in the brain, but it binds to receptors in the kidneys, and it tells the kidneys to hold on to water for the body to remain hydrated. When ADH levels are low, people are urinating frequently, so they get hyperconcentrated in their blood vessels. They're basically dehydrated. And so this is what often leads to the orthostatic changes, the vertigo, the lightheadedness in general, the electric-like shocks, as well as nocturia and frequency during the day. And no matter how much water they drink, they always feel thirsty. So this is a really important one, and these patients are miserable. And then here is that sort of final consequence that as MSH levels decline, we also see, because of the weakening immune system, the permission for secondary infections, including this staph infection that we call MARCoNS. So multiple antibiotic-resistant co-infection, so staph. And it's a very specific kind of staph infection. It does not cause sinusitis, but instead it resides in the deep nasal passages, and it releases a neurotoxin. And it wasn't until recently that the neurotoxin was identified. Actually, our group helped to do that. And it was much smaller than we had anticipated. So we had to bring in a couple very special bench research scientists to help us identify, well, why is it that people who have the presence of MARCoNS are so sick? And we finally figured it out in the last couple months. If that wasn't enough, we also see expression of hypoxia-inducible factor. This is not something you can easily measure, but it influences vascular endothelial growth factor and the production of TGF-beta1. VEGF is important for relaxation or constriction of blood vessels. We see early in the disease process, VEGF climbs, and then it falls. And when it falls, we lose vascular tone and everything tightens up. And it's made even worse by a high TGF-beta1 and also a C4a. So again, not only are these patients hypoxic because of pulmonary issues, but they also have peripheral vasoconstriction. In addition to that, we also see activation of other components of the immune system, so production of cardiolipin antibodies. So we measure anticardiolipin antibodies, D-dimer, von Willebrand's factor. So the blood is actually getting sticky in these patients as well. And then also generation of split products of complement activation. So the complement system is part of the innate immune system, and it's designed to sort of be an early responder. Most times in rheumatology or sort of by immunologists, they're going to measure C3 and C4, but it turns out that it's the alternate cascade that's more important. And here's a clinical pearl. In most patients, the C4a will go up in a biotoxin illness. The upper limit is 2,800 or so. What we found in our data sets when we looked back is that on average, patients with Lyme disease or other chronic infections, their C4a will be around 6,000 to 8,000. Sometimes a little lower, sometimes a little higher, but on average 6,000 to 8,000. If it's an individual who has an active mold exposure, if they're living in a moldy home or they're working in a moldy environment, or it turns out people can have moldy cars. I never really thought about that until recently, but they can. Their C4a on average will be 12,000 and above. So if you have a patient that fails a visual test and they meet criteria by symptoms and their C4a comes back and it's 20,000, you know it's mold. It's nothing else causes the C4a to be so high. Now, the problem with the C4a is that it's hard to get. And don't get confused, because one of the big labs will run the C4a, but they put a stabilizer into the tube, and it artificially reduces the amount of C4a that's available. So you can order C4a, but it won't be accurate. It'll be artificially low. So you want to find a lab company that will ship to the lab that runs C4a. So depending on where you are in the region of the country, you may have to call them and say, how do I get samples to you? It used to be that Quest would send a properly frozen sample to National Jewish. They stopped. So you got to find another resource. I've been working on trying to find a different lab that's all 50 states that will draw and run the C4a properly. We're not there yet. So you got to call National Jewish, because it's an incredibly important marker. It's key to making the diagnosis. And sometimes it's one of the most dramatic, because a lot of the other markers will be abnormal within a sort of range. But sometimes when the C4a comes back, and if the upper limit's 2,800 and it comes back 20,000, and patients say, oh my God, what is this? You say, well, it's a marker of inflammation. They said, no one's ever run this on me before. And you say, well, I know it's kind of a unique marker. And they say, oh my gosh, this is a big problem. And you say, yeah, it is. This is part of what's bridging your blood-brain barrier, and quite frankly, it's frying your brain. That's what C4a does. So there's also another marker you can draw from National Jewish called C3a, but this one is more specific to bacterial infections. So we would like to think the C3a is specific to something like a Lyme problem, but I don't find it to be as accurate. I don't find it to be as reliable. Oftentimes when we have positive Lyme tests coming back on NanoTrap, for example, and their NeuroQuant is specific for Lyme, their C3a is still normal. When it is high, when it's above 700 or so, it's very accurate. So these patients definitely have a bacterial infection if the C3a is high. So it's it's specific, but it's not sensitive. The C4a, on the other hand, is wonderful, because to me, it's very reliable in terms of, yep, something is going on. Now, I've had patients where it's mold, but their C4a is 5,000. It's not dramatic at 15,000. What that typically means is that they've had a mold exposure, but it's sometime in the past. So it could be your 45-year-old who had a mold exposure in college where the C4a was probably high at that time, but it's slowly fallen. But it won't go back to normal because they have the presence of the HLA sequences. And then there's a variety of other inflammatory markers like MMP9 that we like to measure. This is vascular inflammation. It breaks down connective tissue. It's a very good marker of Th1 imbalance. We don't measure IL-1B. So this is the set. So what can you measure? You can measure leptin, you can measure VIP, MSH, AVP. You can get saliva melatonin if you want. You can even check tight junctions in the gut. You can definitely get cortisol and ACTH. You can get reproductive hormones. You can get ADH and osmolality. You can swab people's noses for MARCons. You can check a TGF-beta1 and a VEGF. You can check anticardiolipin antibodies, D-dimer, von Willebrand's factor, C4a, C3a, MMP9. That's your set. That's your language.
Can you repeat it again?
I'll go over it again. Here are your HLAs. So you actually can order this from, ask me,
Where?
LabCorp. Actually, all of these you can get from LabCorp except the C4a and C3a. You can get them all, including their HLA. Because I keep talking about this, but you might say, well, okay, Dr. Heyman, but how do you know? Well, this is how you know. So you can actually order an HLA DRB DQB. And so the HLA, you'll get a whole bunch of gobbledygook back on the lab report. It doesn't come to you prepackaged in the correct SNP sequence. And if you notice, you'll get all of these markers, sort of nomenclature, DRB1, DQ, DRB3, DRB4, DRB5. And there are certain HLA sequences that are what we call multi-susceptible, meaning that whatever the person has been exposed to, it doesn't matter, they're going to get sick. Some HLAs seem to be specific for mold, for Lyme, for dinoflagellates, for Marcons, for just low MSH. We have found, though, that even some of these mold HLA sequences, they're probably multi-susceptible, like the 13.6, where people can get sick from Lyme and from mold. So you get your gobbledygook back, and you say, well, how do I get it into a form that I can then check to see, well, what type of susceptibility pattern do they have? So I've given you the process for how to do this. I'm not going to go over this now. It's something you need to sit down with. But this is the sequence for when you get your gobbledygook back to be able to sequence it back into the correct exposure. There are also online HLA sequencers. I don't remember the URL, but it will say, okay, what is their DRB1, what is their DQ, what's their DRB3, you put it all in, and then it tells you what they've got, okay? So you got to do a little bit of work in terms of interpreting their HLA. It's not straightforward, and don't be intimidated. It's going to be a lot of lines of numbers, and you know it's a little confusing, but if you just sit with it, you can either learn to go through it, or you can put it into your online interpreter. But this is what you're looking for, is to say, okay, yep, you're in this category. And the top ones, the multi-susceptible, these top two create the most vulnerability. 4.353b and the 11.352b are the ones where people get the sickest, and they're the hardest to treat. And in particular, interestingly, the 11.352b is also associated with connective tissue issues. So there's actually a subset of patients within CIRS where they're very loosey-goosey, and they have an Ehlers-Danlos type picture. Why is that important? Because the connective tissue spindles are so loose that the immune cells that typically reside there, called Th17 cells, overexpress TGF-beta1. And so these patients tend to have much higher levels of inflammation. So if you ask patients, can you bend your thumb back and touch your forearm, or can you do the other Ehlers-Danlos test? And sometimes they don't sort of meet full criteria, but they're like, oh, I've always been very flexible, so on and so forth. And you get their TGF-beta1 back, and the upper limit is about 2,300. And I often see patients in the 5,000, 6,000 range. But if they come back and it's 32,000 and they're an 11.352, you know they have a connective tissue issue. The problem in this patient population is not only do they have that, they often have dysautonomias, and even worse, mast cell problems. So they tend to be very histaminic. That's the triad of dysfunction that we see. These patients are very hard. So and with the connective tissue problems, we see patients with Chiari malformations, as well as pelvic floor dysfunction. They're often getting adjustments constantly because they're in pain, but the adjustments never hold. Oh gosh, you know, it's a left on left sacrum again, and I just can't get it back. I got it, and then they're back 2 days later, and it's so on and so forth. These are patients that will be systemically inflamed because they're looser, and it's genetically driven. So they're more histaminic, they have more pain, they have more somatic dysfunction, and they're harder to treat in general. This is the pro-level version of dealing with CIRS. This is really difficult stuff, and I'm not so sure any of us have quite figured this one out. So what you're trying to do is sequence their HLA, and you can get that from LabCorp, and this is how you do it. We also know that there's so much immune dysfunction because Th17 levels are triggered. And why? Because Treg cells start to lose their drive. So Treg cells regulate Th1, Th2, Th17, and as Treg cells decline, we see higher activation of Th17, meaning excess production of TGF-beta1. So you can measure TGF-beta1. Patients say, well, what is that? You just say it's a marker of inflammation. What it really is a transcription factor. So as TGF-beta1 levels go up, we see excess gene activation. We also see higher risk for interstitial lung disease. We used to be able to measure Treg cells, but I think LabCorp stopped. you could order CD4, CD25. Anything below 3 we found in our data sets meant low Treg cells. So we're seeing a weakening immune drive in this patient population. So TGF-beta1, marker of inflammation. Normal is less than 2380. If it's over 10,000, essentially guaranteed restrictive lung disease, tremors, cognitive issues, and joint problems. It degrades the blood-brain barrier and induces gene activation in the central nervous system. So it's one of the main markers for creating that sort of brain on fire phenomenon. Vascular endothelial growth factor, again, responsive to that hypoxia-inducible factor. There's also feedback from TGF-beta1 itself. It's meant to increase oxygen and increases new blood vessel formation. And when it declines, again, we see constriction of the blood vessels. I'd also mention VIP, vasoactive intestinal peptide. Originally, the work that was done on it many years ago in the 1970s identified production in the gut. It's also produced in the lungs, the respiratory tract, and in the brain itself in that anterior hypothalamus. And so it's a neuroregulatory peptide, and just like MSH, it will decline under higher levels of cytokines. It will bind to membrane receptors and activates intracellular regulation, and it downregulates cytokines, including MMP9. So not only is it a marker of dysfunction, we actually use it therapeutically at the end of treatment. So interestingly, one of the other epiphenomenon of this inflammatory process is that it also downregulates the vitamin D receptor. And so if you're often measuring vitamin D in your patient population, you'll typically see a very high 125 hydroxyvitamin D and a very low 25 hydroxyvitamin D. If you have patients that have fatigue and brain fog and headaches and their vitamin D levels are 15 or 20, and you keep giving them vitamin D and their levels just won't come up, it's likely this. So VIP actually corrects the vitamin D receptor. And so we don't typically give patients vitamin D. We just give them VIP at the end of therapy, and we'll see the vitamin D level normalize. It's amazing to watch, actually. So in the same way that we don't necessarily give a lot of testosterone if the aromatase enzyme is activated, we don't give a lot of vitamin D if they've downregulated their vitamin D receptor. So don't get fooled. You know, this is the one thing where, to me, it's the Achilles heel of functional medicine. If cortisol levels are low, we spend all of our time trying to raise it. If vitamin D levels are low, we spend all of our time trying to raise it. If testosterone levels are low, we spend all of our time trying to raise it, without really asking the question, what is driving this phenomenon? What is the cause of all of this metabolic disturbance? And so it's a trap that we've fallen into as a community, and I'm guilty of it as much as anybody else. But earlier today, the question was, you know, kind of a question around what sort of products do I use? And when you look at my formulary, it's changed so much because of how we treat this patient population. We're not doing a lot of that stuff. I'm not handing out a lot of vitamin D anymore and adrenal support and all this sort of stuff. I used to. But when you figure out the underlying mechanisms, you stop reaching for the normal stuff and you start reaching for sort of the weirdo bottles that actually begin to correct these issues. And we'll go over all of that. So this is an important point. We reserve VIP for the end of therapy. It's a nasal spray. It has to be compounded. This is where I'm going to give you a big apology for the non-prescribers in the room. I wish we had something else available to us. But right now, this is all we have. And the VIP, as it binds to the cell membrane, it not only corrects the genomic aberrations because of its intracellular signaling, and we've shown this in pre and post studies, I'll show our data, but it also repairs the brain. So we've shown improvement in brain architecture using VIP. But if you use it inappropriately, if you use it too early in the course of therapy, then you're not going to see improvement. So you have to have these criteria. They have to be out of mold, meaning that ERMI score I'd mentioned is less than 2. They have to have normalized their visual test, and they've cleared their MARCONs. And their lipase has to be normal. So you can't give VIP without meeting these criteria, okay? Or it won't work. The HERTS-Me is a subset of ERMI. So typically speaking, we'll have people do an ERMI swab for a baseline mold test. Then they remediate, then they do a HERTS-me, which is a more narrow set of mold markers. And we know that there's about 6 of them that we really want to track and follow as they clean up their environment. So it's Wallemia and Stachybotrys and Chetomium and a few others. So URMI is a big test. HERTS-me is more narrow and follow-up for remediation. And it's scored a little differently than the URMI test. So what about that Marcons? Well, it's a biofilm former. It produces extracellular products. It's genomically active. And the prescription takes months to clear. So we give them a special nasal spray. We have patients use it for 6 weeks. Then they re-swab their nose to make sure that they've gotten rid of their Marcons. And it turns out that Marcons itself finds a reservoir in damp buildings and also the noses of dogs. So if patients don't clear their Marcons and they love their dog and they're playing with their dog, and it could be that they're re-inoculating themselves. And I have dogs. I love my dog. So I get it. So dogs can have it. So yeah, actually animals can get CIRS too. Horses can get it. Dogs can get it. This is not limited to just humans. So EPM, for example, in horses, it's CIRS. Yeah. EPM, don't worry about it. So I'll get to it. Yep, I'm going to get to it. And, so all the treatment is coming after this talk. So I'm just kind of setting you up for the labs and evaluation. So you might be asking, all right, Dr. Heyman, well, okay, you've sort of talked in general terms. I want a little even more specifics on each of the lab markers that you've mentioned. So we've done kind of a 30,000, then we did a 10,000, and now here I've given you all of the information for each of the markers, including the normal range. Okay, and I want to point something out. Sometimes the stated normal range on the lab test is not the range that we use. And often there's a good reason for that, but sometimes it's not a great reason. So for example, melanocyte-stimulating hormone, you might say, well, you're saying that the normal range is 35 to 81, but the stated range on LabCorp says less than 40, right? And so you say, well, I don't understand. And the reason why is because in Maryland, we won a court case. And it was an individual who was harmed at work by a moldy building. And the insurance company had to pay up millions of dollars. The case hinged on MSH. And so we showed all the data on MSH. And we won, and the insurance company had to pay. It turned out that LabCorp was a part owner of the insurance company. 2 weeks later, the range changed. So use the 35 to 81. I can actually show you old lab values from patients where they used to say 35 to 81.
Old before.
Before the case. So use these ranges, okay? It's not always the stated range on the lab. Sometimes it is the same, but these are the correct ranges that I want you to use. For VIP, for MSH, for TGF-beta 1, for C4A, anti-gliadin antibodies, ACTH and cortisol, VEGF, anti-cardiolipin antibodies, ADH and osmolality, MMP9, and leptin. You have all of it here for you, okay? So all the detail. I don't want you to struggle. I've given you the interpretation for HLA. I've given you my visual contrast study handout. I've given you ranges for labs. I've shown you the cascade of events for how these labs become abnormal. So once you see it, your life as a doctor will change forever because the labs will come back abnormal and people will fail their visual test. And you will say, holy, how could I have practiced this long and not known this? And you'll also begin to second guess yourself because it's so many patients. And once the word spreads that you're fixing these people, you will never run out of patients. I guarantee it. They're everywhere. They're everywhere. And mold is everywhere. And tick-borne illnesses are all up and down the East Coast, and there's some on the West Coast, and there's all sorts of other biotoxins that we can encounter. So this idea of sort of lack of regulation of inflammation is key. Again, it's a problem in the innate immune system. It leads to hormonal dysregulation, capillary hypoperfusion, and now lower Treg cells. Well, you can't really see that. All right, so you've seen this, though. We've already actually gone over this. Okay, so we know that this is about symptoms and visual test. We verify with 3 of 6. So visual contrast study, MSH, MMP9, ADH cortisol, or ADH osmolality, ACTH cortisol, so on and so forth. And then you think about your diagnostic refinement. So what does a visual contrast study look like? Well, this is a report. This is one of my patients. And what you'll get is a grid, and you'll get a score at the bottom, and it'll say pass or fail. Okay, so they did the left eye and they did the right eye. And then they can send you the report. And you say, yep, you got all the symptoms and you failed your visual test. Away we go. I know what I'm doing now. What do some of the markers look like? I'm very visual. I want you to actually see what these labs look like. I'm not going to just describe them. So I pulled some labs for you all. So sometimes patients ask about the CD57. They think it's very specific for Lyme. It's not. That's based on one poor study in the literature. CD57 will drop in any biotoxin patient. And if you don't correct their underlying inflammation, their CD57 typically won't go up. CBCs tend to be normal. In this patient, they had a normal antidiuretic hormone and osmolality. So what you'll often see is this discordance where it'll be reported less than 0.8, so very low ADH, but their osmolality will be 290 or 295, that they're getting pretty hyperconcentrated. And you're saying, well, why is that? Why is the body not responding and sort of keeping them in a normal range? And it's because of the brain inflammation. This is not a person who mounted anticardiolipin antibodies, but many people do, so their blood would be getting sticky. This is a patient who had an elevated MMP9. It's 501. Anything above 332. Now, the stated range says less than 984, which is crazy. We've actually sent formal letters to LabCorp with literature saying, why do you insist on 984 when we can show you all sorts of studies that it needs to be much lower? And they won't change the range, but that's okay. So just know anything above 332 means activation of this inflammatory marker that's breaking down connective tissue. Here's more proteomics. TGF-beta 1, highlighted. The normal range, 2382. This is a patient who had 7100. So they're frying their brain, they're frying their lungs, they're getting pulmonary hypertension and poor peripheral blood flow, and they're inducing abnormal gene activation. We also will run the normal C6 antibody test in addition to the two-step ELISA and Western blot. This was normal. Sometimes patients will have an abnormal D-dimer. And here we go. So MSH, melanocyte-stimulating hormone, the stated normal range, 0 to 40, basically meaning you could have no MSH and be totally fine, right? Which is not true. So it needs to be above 35. So it's 35 to 81 is the normal range. This person was low at 20. So don't get confused, again, on the lab report. And then here's that C4A, the alternate complement pathway. So quick quiz question. Is this a Lyme patient or a mold patient? Mold. Because it's above 12,000, right? It's 17,695. The upper limit is 2830. And patients will say, oh my God, what's wrong with me? What is this marker? I've never seen this before. And it's just a marker of inflammation. So that's a little better. So we've gone through this again. I've shown you the visual contrast study and the symptoms. We've gone through the lab testing. And then we get into some more of the diagnostic refinement, meaning if I'm looking for microbes, what are some of the microbes that I look for? Well, mycoplasma, all the tick-borne illnesses, Epstein-Barr, HHV6, CMV, toxoplasmosis, HSV1 and 2, streptococcus, and then mold. Those are my big ones. So
a lot of patients will be mycoplasma IgG positive. Does that mean anything?
So the question is, what about the patients who are just IgG positive? So back to sort of immunology 101, IgM positive means active current infection. IgG positive usually just means a prior infection. So there's a great debate, though, about does it mean prior or chronic? And the rule of thumb is if the IgG level is 4 times normal, it's likely chronic. Not always. So we kind of squint and say, if it's quote unquote really high, we think maybe they have a chronic infection. So it's worth treating, but with an asterisk, okay? Because a lot of your local infectious disease docs will say, oh, come on, it's just an IgG, I don't care about that.
And that's for all infections?
Yeah,
Even if it's IgM negative?
even IgM negative. This is the art of medicine. And all I'm saying, there is an instance where I've had patients where they're just IgG positive for like Epstein-Barr or Mycoplasma. We treated them and they actually did better. They felt better. And their IgG levels actually came down. Now, they never fully went back to normal, but I felt like, okay, maybe we needed to do that with them. So Lyme, no one really likes to talk about Lyme. It's scary, it's difficult, these patients are terrible, but we're giving you a roadmap for how to look at them now. You know, oftentimes we feel like they're sort of clinically impossible because they have so many symptoms, but now we're beginning to articulate what that is. I talked about the antigen test. This is that urine nano trap, has high sensitivity and specificity. Here's the result. So this is a negative nano trap test. So I put it in, and I like for people to actually see the results. So all it's going to report is positive or negative. That's all you get, meaning there's the presence of the antigen in the urine, meaning bits and pieces of bug. So if it's positive, it's 100% specific. And all pathogenic forms of Lyme express outer surface protein A. So as we're going through the list, you say, okay, maybe I'm going to run a nano trap, but let's swab the home. So let's say their C4A is 10,000. High enough for mold, could be Lyme, not really sure. We might have them spend some money on the nano trap test and swab their home. So we know it's based on PCR. There's a more specific form called HERTS-Me2. We do this as the follow-up after remediation, but this is the big one. And it won't capture everything. So we know that there can be elements in the home that the ERMI test doesn't account for. We're just looking for mold. The HERTS-Me2, which is basically 6 forms of mold, are incredibly accurate. And the same company will offer both the ERMI swab kit and the follow-up HERTS-Me. So this is what an ERMI test looks like. You're going to have group 1 and group 2. The mold forms in group 1, which is above here, ending with Wallemia, is scored. And this individual had a lot of Aspergillus, various forms of Aspergillus. They had Cladosporium, they had Wallemia, they had even some Stachybotrys. And there are also other forms of mold that we don't think are pathogenic for individuals. Another piece, because I know this is sort of a big topic, fungus as a kingdom has mold and it has candida. Mold is not candida. You don't treat mold with cat's claw and caprylic acid and diflucan and nystatin and all the rest. It doesn't work. The other piece is these guys are not growing in your patient. So when the patient says, I have mold, I'm growing mold in me, that's gross. No, it's not so much that they have mold in the way that candida can colonize the digestive or respiratory tract, but instead, as they breathe in the mycotoxins, they're getting this enormous inflammatory response. It's the immune activation that's the problem. Now, sometimes when we swab people's noses, we can see a little mold growing in the nose, but it's not that they're systemically colonized, okay? Also, in conventional medicine, when you learn about mold-related illnesses, you either have a mold allergy, IgE, we say, okay, you go into a moldy room and you get a little stuffy and itchy, watery eyes, or you're breathing in histoplasmosis or other things and you're getting a terrible pulmonary infection and you're in the ICU. It's really kind of one or the other, right? What we've done is kind of categorize the muddy middle, that there's a different inflammatory response to mold that can make people persistently sick. It's not IgE allergy, and it's not a respiratory disaster either, okay? It's something in between. So I want you to understand that as well. It's not candida. It's not treated with anti-candidal approaches. People don't get better. And I see practitioners make this mistake all the time. They think candida and mold are the same thing. They're both fungus. but they're not the same. One is a single cell organism and the other is a multi-cell organism. So they're very different. So we do the URMI swab kit. They swab their home, they get a little dust cloth, they swab in 10 areas, they send the sample back off to the company, and they get a report. And what we're looking for is this final URMI score. Anything above 2 means there's too much mold. Okay, so that's the cutoff. And this patient had 10. Yeah, 10.51. So that's too much. Now, it doesn't tell you where it is, okay, but it does tell you they have a problem. One of the stickiest components of this whole process, I find clinically, sort of management-wise, is how do we help patients remediate their home? And there are really 2 things they need to understand. The first is there's going to be a cause somewhere. It's either mold growing in the HVAC system, or the ductwork, or it's behind a wall, or there's water infiltration in the kitchen or somewhere, or in the attic, because of poor ventilation or poor building practices. So you got to find the cause or the source, wherever that might be. The problem is they're not done when you find the source, because mycotoxins and mold spores are very light and they are easily expressed off the mother colony, and it means the whole house is contaminated. Just because you've dealt with the visible cause does not mean that you've also dealt with the consequences, meaning every surface, everything in the home needs to be cleaned. And the reason why that's important is because if you carry the HLA sequences, there is not what we call a dose-response relationship. People who are vulnerable, even if it's a small amount of mold, will make them incredibly sick. So they can mount a C4A of 20,000 even though they've cleaned up the source, but all the utensils in the kitchen and the rugs and the clothing and all that wasn't dealt with. Everything in the house has to be cleaned. It's all contaminated. And that is a huge burden for people, but it has to be done. And they say, well, it's time consuming, it's expensive, and we say, look, do what you can within your budget as much as you can, even on your own. One of the best ways to kill mold on surfaces is this takes me back to college days, you can buy some old grain alcohol and do a 1:10 ratio with water and put it in a spray bottle and spray all the surfaces down with grain alcohol. So I've also given you all the information on what is the URMI test, the phone number for the company, the whole thing. So this is what we give out to patients to explain, why are you swabbing your home? And they might say, well, I bought a little kit at Home Depot, or I contacted my local testing company and they did air sampling and they told me it was normal. And I say, I know you spent money, but I'm sorry, I'm going to ask you to go back and swab, because it's much more accurate than air sampling and it's far more accurate than what you can get at Home Depot. So just trust me on this one. Your C4A is 20,000. I know there's mold in your environment somewhere. So let's not make the mistake of overlooking this thing.
Question.
Mm-hmm.
If you have a C4A of over 20,000, are you pretty sure that there's current mold in their environment?
Current. That is absolutely.
If they were 20 years old when they got the mold exposure, then it's going to be 5,000.
It could be lower. It could be lower. Yeah, if it's above 12,000, if you're kind of in that 15,000 range, they're breathing it in within 4 hours of when they drew their blood, because that's how quickly the C4A will go up, within a couple hours of the exposure. You can also do some of your functional tests, so we're back on maybe more stable territory. Salivary cortisol, food sensitivity panel, functional GI tests, lipopolysaccharides, diamine oxidase, mast cell activation labs, and blood-brain barrier tests. These are all available to you as functional tests. And all of these are sort of within reason. I put these in here because some of you might order at least a subset of these. There's a nice company that does blood-brain barrier tests now that I'm beginning to use and getting some nice results, just to kind of verify the degradation of the blood-brain barrier. CIRS does that test. So they were really known for sort of testing for gluten. Okay, big deal. But even better, now they're testing for blood-brain barrier proteins.